Hello, everybody, and welcome to our third training targeted to sales teams and sales people from our partner side. So today's training is with Dr. Chris Prue, and it's going to be about the sports and running introduction or approach to practitioners. I will leave the floor to Chris to introduce his topic, and please feel free to share your questions in the questions tab or in the chat. And if you would like to talk, to join in with your microphone and camera, just tell me on the chat and I'll invite you in so that you could live participate with us. Thank you for being here, and it's to you, Chris.
Thank you, Rana. You can all see I've got my new Digital Pro shirt on, representing here. All right, let's see. You gonna
Okay,
share my
I'll
screen?
leave you on your own, and but I'll be here.
Okay. Oops. All right. Can you see it okay?
Yes, Chris, we can
All
see
right.
your full screen. Perfect.
Making sure.
Yeah.
Okay. So, as Rana said, again, thank you. So this is a follow-up as a part three as we look at sort of the evolution in reaching out to customers in terms of how they can implement and utilize the DS Pro product. So this one is specifically going to focus on the running application, which has implications certainly within the clinic and working with the active population. And that's variable. It doesn't mean that they have to be professional athletes. So I work with a lot of athletes who are recreational. They just want to run. They enjoy running. They want to do a better job at running, even though that they're not maybe going to go to the Olympics. In fact, most runners will not make it to the Olympics. And so it really provides an opportunity to enhance the delivery of care to that particular population. So, sort of working around the circle and the door concept of the various groups that we can work with, even though it's considered one system, just like other tools, there are variables that are different from one population to another, and this is just another one of those populations. So we're going to look at the sports group, but just again to remember that we've covered the elderly population, we've covered the youth population. So this is just another aspect, another opportunity to get into the clinician's hands a tool that they can use as a broad spectrum to treat a very large, diverse population of patients. And sometimes some of us treat that diverse population, or maybe this is a group that you haven't had an opportunity to target yet because you weren't sure exactly where that sort of fits in. So, as I mentioned earlier, it meets the needs of certainly that more physically active population. Not everybody can run, all the way up to the healthy athletes. So I use our system as an outreach program as well. So I can use it to evaluate a runner as well as use it as part of the training. So we use the data that we collect from the Digitsol Pro, and it informs some of the characteristics that we might need to change with running. For example, the way that they contact the ground, which we'll talk about here in a moment, up to if I find that there is some deviation in symmetry and contact time, maybe they've got some weaknesses, and we'll create a training program to enhance that aspect. So it goes in both directions, right? Because anytime that there's an issue and maybe the characteristics of their running, if they're not injured yet, they probably will be injured at a later date. So we actually have an opportunity not only to improve their performance, but potentially reduce their risk of injury and creating sort of that patient situation. But in the clinic and working with the patients as part of our assessment tools that we can look at when we do characterize a patient and try to identify through diagnosis what exactly their condition is. That's not hard, but it's looking at the causative factors, right? Trying to determine what was the cause of that particular condition. And that's where the data, the DS Pro system really allows us to provide this functional test that gives us these outcome measures, as well as the surrogate measures, right? So it gives us the performance aspect of overall running, but also we look at the various components of running that we're going to cover here in just a moment. We will address, and we can use that within some of our other assessment and evaluation tools to further narrow down exactly what the problem is or what we think we need to do with that particular patient to get them back to where they need to be. So when we look at runners, the cause of injury, a lot of it has to do actually with their training. The majority of the conditions are because of training, and a lot of times these types of patients or athletes, they never want to stop. Right? If you're a runner, you usually enjoy running, or it's embedded in your activity, your lifestyle. You get mental capacity from it. There's many reasons that people actually will run, and it's not just because of performance or for competition. Other reasons could be because it has something to do with their shoes or their technique. But in any event, knowing that, looking at all the characteristics or the causes of injury is really important, because we need to determine and figure out, minimize that, and possibly change some of the characterization of how they actually run, right? Because if you think about it, running is very repetitive, just like we do with exercise or other physical activity patterns that we're trying to improve or get better at. And so when we're running, it's like an accelerated rate, and there's a very, very, very high volume to that repetitive nature. And that's why the runner is highly subjected to potential injury if things aren't going really, really well. And it's from all of these different conditions. I used to coach in track and field and work with a lot of runners, and even in USA track and field, we always had a joke that, if you weren't injured, you were not a real track and field athlete, because they're embedded with so many injuries, especially in these long distance runners, because of that repetitive nature. That's not really a true statement, but we do see there's a lot of chronic and overuse injuries in that particular population. So we're going to look at a high level running review. In other words, we're not going to get into a lot of detail. There is some detail here, but know that if you knew everything that we're about to show you, you would probably know more than the majority of those clinicians. So what's going to happen is, and you probably already know this, there's really two levels. So there's one level that these clinicians or these sport coaches specialize in running. So they know running very, very well, and they're going to be easy to be able to show them the device and what we can accomplish with that. And then there's the other group, which is actually more of the majority. Those are the people that are not going to have a good understanding of running. Why? Because they haven't had access to this type of information. They haven't had access to this type of technology to be able to evaluate it and really make it part of their practice. But what's unique and an opportunity here is to expand in their practice and to show them that they actually can implement it and expand the diversification of the patients that they're dealing with. Even if it's a very small amount, if we see an increase in 10% of the patient population, well, that's typically, somewhat of a 10% increase in revenue, right? And more referrals and things like that. So it really starts to build and provide more opportunity. As I also mentioned, that this is also the type of application that we can use as an outreach program. And some of you already know some of your customers that go to the communities, they go to some of these races, and they go to some of these running stores, and they provide this as a service. And it turns into an opportunity to gain patients or clients that maybe have some issues or want to do a better job with regards to their overall performance. So we usually characterize, and we'll get into the gait analysis here in a moment, but there's typically two variations to how most people are going to run. So it's referred to as a posterior and anterior, or we're also going to refer to that as a heel strike or a midfoot or forefoot strike. And the reason I think that that's also a very important aspect in how we discuss that is because that's one of the characteristics that our system actually measures, right? And so there are some advantages and disadvantages to both of these running styles, but know that a lot of us kind of shift towards one style versus another because of some of the mechanics and the reduction in potential injury. So as a result of these two different running styles, it does change some of the mechanics. It does change some of the muscle activity patterns. It even changes the strike pattern as well as the force at which someone strikes. It also changes their step length and their overall stride length. So there are some differences between these two gait styles, and it's not dissimilar to when you look at the difference. If you look at this picture over here, running at different speeds, 3, 4, and 5 meters per second, we see that just changing your speed also changes the characterization of how we run through the running gait cycle. So there are many different considerations when we are evaluating that, and that's why this could be somewhat complicated. And then I want to make an example here that when we run at 3 meters per second versus 5 meters per second, even at the 4 meters per second, that a 10% increase in running speed, running velocity changes some of these mechanics. And I want to present that to you as also an opportunity as part of the assessment. And I'll talk about that a little bit more. But to know that we have some different changes based on their strike pattern, as well as based on the speed at which they're going to run. And both of those, we actually are able to measure and capture that information, provide that information to the clinician so they can use that to inform some of the changes in the technique or maybe some of the interventions that are going to be required with regards to how they're going to make this person better and be able to run again. So this is the posterior cycle as we look at with regards to sort of this heel striking pattern. So we have different phases, right? The amortization phase, the support phase, the thrust phase, and then the suspension. All of these different phases have different characteristics to the mechanics, but also the muscle nature of the movement pattern. And what we find is that when people do heel strike, they tend to have a larger downward strike pattern. And so as a result of that, with the heel strike, they've sort of removed the ankle from the ability to absorb some of that shock. So the responsibility is going to be a little bit elsewhere. We also find that they tend to have a longer stride length, which in certain instances is actually of an advantage when we're looking at running speed. They tend to have a slower cadence, so the energy expenditure could be a little bit different versus the one we're about to look at here in just a moment. The characterization of that running pattern, it's not opposite, but it's a little bit different in the absorption as well as some of the utilization of the overall energy. So most of us like to use the anterior cycle, which I'll show you here in a moment. And some of us will actually transition these heel strikers as posterior cycle to, someone who is moving to a different strike pattern. So in this anterior cycle, they look a little bit more like someone who might be sprinting. So their contact phase is going to be more of a midfoot to a forefoot. And what happens is the angulation of the ankle is such that it results in some of that absorption. So we see that the peak striking force and the rate to the peak striking force is different. It's a softer landing. So there's a lower impact force as a result of that. So it's using more of the musculature, but not just contraction. So remember that muscle tissue is also elastic, and we use that to our advantage. So in running economy, running economy is your ability to utilize energy very efficiently. It's kind of like an automobile that, runs on smaller cylinders, and you're not driving too fast, and you get more kilometers per liter. So we don't expend as much energy when we have a better running economy. So that elastic nature of the muscle profile actually gives us about 30% of our running economy comes from that. And that's why some of us will transition to some of these different strike patterns, because it changes the mechanics and allows us to capitalize on some of these other movement patterns. So these are just really the two different cycles. And again, you shouldn't be probably teaching unless you're very familiar with running gait as a program. We do have a partner that Roman works with, that runs these specialty programs that can better inform some of them if they really want to get into that. But we're just kind of looking at this high level overview and focusing on the characteristics that our system can actually measure. Excuse me. So real brief again, looking at this impact absorption. So these are two pictures I sort of imparted to look at what's going on when we heel strike versus when we toe strike. This is actually not the best picture, because we tend to see there's a greater reach, there's a greater step length, which gives us a greater stride length, typically in the people that are going to heel strike. So their center of mass is in a different position. It's actually behind where their strike pattern is. So they require, a little bit faster velocity to have a longer stride length and turn over and change that center of mass, versus if you look here, there's a midfoot strike or a forefoot strike, greater absorption in the musculature, but their center of mass is more over that base of support where they tend to contact. And so there's a shorter stride, and as a result of that, a shorter step length. That does actually also change the way that the musculature will inform the gait cycle. So if we have to have more potential absorption with the posterior musculature as well as the anterior musculature when we heel strike, there's potentially some differences in energy consumption between the two. But what we find is people that tend to heel strike, they have more of a braking mechanism, because their center of mass is much further behind that forward leg as it's impacting. And again, that changes some of the efficiency patterns. It changes the heel strike pattern. In general, most people think, especially from a contact force point of view, that the midfoot striking pattern is superior. We still have runners that do heel strike pattern, and they're more superior in terms of their performance. And partly it's just the way that they grew up as a runner and how they were able to develop their level of performance as they ran through. Sometimes it actually has to do with the shoes that they're also wearing as a result of learning to run. So if you wear a very low profile shoe, or you're a barefoot runner, you're never going to heel strike, or you're going to start to have some problems. And that will be an issue with regards to your future performance. Versus if you look at the data on barefoot running, we know that they do mid and forefoot strike because they need to be able to absorb that energy. The calcaneus or the heel just doesn't have the mechanism that's necessary to absorb that level of shock and not become injured. So this is the group that I was referring to a little bit earlier. And so they have a certain philosophy in how they run their programs. And they do emphasize a lot looking at the vertical loading rate, or the contact strike force, and how quickly we reach that peak force, because that's an indication of the type of strike pattern. It's also an indication of potential future injuries. And so we try to minimize that, as much as possible. We tend to move to a forefoot or a midfoot strike attack. Shorter contact times means that we're turning over that pattern more quickly. So if I maintain the same stride length, but I had a shorter contact time, that means I'm going to have more steps, and I'm going to translate that into a faster running speed. And that actually is one of the training aspects of then, influencing the cardiovascular system. So it's this constant. So they have this philosophy of sort of this air run, spending more time in the air than you are in the ground. So other characteristics and things that we use to test that. So we've got other tests that provide us some of these metrics and give us the ability to look at what are the things that we actually need to change. So our system integrates with some of these other tests to know and separate out, well, do we need to focus on more strength? Does it need to be more plyometric activity because we want to decrease that? I'd mentioned earlier that amortization phase. So that amortization phase is when we ground contact and we turn that over into flight time again. So plyometric type of training is designed specifically to reduce that, but we also have to be stronger. And so some of these other tests help us and give us that ability to tease out, as we say, or give us some of that information to lead us down the intervention path. So we're not saying that we're necessarily going to remove all of these other tests. However, what it is doing for us is giving us more of that performance-based outcome measure that typically the way that some of these clinicians are analyzing that, they don't actually have some of this data. So they're relying on some of these older tests that many of them do have some correlation, but they're minimal because they're not really designed for necessarily that performance aspect. So now we actually have a tool that really is honed in or focused on looking at the performance aspect of running and really what is necessary. So some of the parameters that probably all of these clinicians should be aware of, especially if they are in that running. But even here, we still have a lot of these running specialists that are literally just watching somebody or recording them on their phone and making all of their determinations based on that. It's impossible. You cannot get all of the metrics that are especially important to looking at some of these characteristics to determine whether or not they need to make some changes or exactly what needs to change. So most people are very familiar with the different contact phases. But again, what they're typically looking at, if they're not using a technological system, is they're just looking at a camera or they're looking at visually and they're looking at how they attack and whether they're heel striking, midfoot striking, or forefoot striking. And they're using that to compute some of their information. And then they'll go to the back of the treadmill. Some people actually do this and they run behind, or I have a colleague who drives their car next to a runner and attempts to do their analysis because they consider that to be more of an appropriate method. Real life, but real life, that's not exactly how that works either. So they're attempting to look at the pronosupination angulation, which again is difficult enough even on a treadmill with a high-speed camera system, let alone driving behind someone in their automobile using their camera phone. So that's what we use to then determine, do we need to post them on the medial or the lateral aspect? Do we need to change their shoes? And so many people are configuring and using that as their high level of information to make those changes in the clinic. And it doesn't work. It may work to some extent. I mean, there are some dramatic deviations that we can see, but some of those real technical aspects is nearly impossible, especially as we start to move along the cycle, right? So our ultimate goal is someone comes into the clinic and they're injured. We perform something that gets them out of pain, something that gets them out of inflammation, especially if it's a post-operative procedure. And then we start building up their running profile again by going back to the basics, making sure that they have the appropriate strength, making sure that they have the appropriate proprioception and the mechanics that are necessary to perform. And so that's the reathleticization. And then we get preparation to return to sport. And so many people have utilized this time effect, this time constraint following post-operative procedures. And I just gave a presentation last week, for example, and that there's a call to action by the physiotherapist in the United States saying that, in these clinics, we need to do a better job. It's not just based on time. That return to sport needs much better information and calculation to determine that they're actually ready. And those are some of the characteristics that we're able to capture with our system. So what are the quantifications that we have? We have several. There are many that provide us a lot of high and low level information. High level information meaning just some real quick information, looking at a dashboard, for example, looking at their speed. And with their speed, we also know their cadence. And the system very easily, based on the demographics or the anthropometrics of the patient, can determine whether or not they're in that right profile. Based on their speed, they should have a certain cadence and they should have a certain stride length. So our system already characterizes that. And even when I just look at that initial dashboard, if I see that they have a low cadence based on their speed, I already know something that I need to change, right? And so that's a real simple, as we say, high level, that it doesn't require a lot of technical aspect, a lot of technical detail. And so that's something that's real easy to teach someone who maybe isn't doing this, right? Even if they're not the coach, just knowing this information dramatically changes things. Whoops, I skipped one point down here. Comparison to a standard. So we can also look at the day-to-day variations of when we're testing. We also can look at different variations within their specific run time. For example, oftentimes patients with patellofemoral pain syndrome, they can run their first 1.5 kilometers and usually things are fine, but then they start to become painful after that 1.5 kilometers. And we can actually look at those 2 points and evaluate what was working when they were running correctly and what changed as a result of their pain. We can also look at and map the evolution. So I just gave a lecture on long-term youth athletic development. And one of the characteristics that we need to look at and do a much better job at is looking at the evolution through the years. But certainly when we're looking at this in a rehabilitation situation, we need to see the progression and the changes in the evolution of all of these different patterns and metrics that we're dealing with as we're working with this athlete to make sure that they are progressing appropriately in those specific areas. The basic profile, so we know that we get percentage of stance or contact time, we get percentage of flight time, and we also get percentage of double flight time. And within that, we can see that we have the stride length, very easy. We can see it shows up on that dashboard. And again, looking at that symmetry or asymmetry characteristic, like to me, that's one of the most important and quick things I look at, because that's giving me the comparison between ground contact time, right? And in some of our studies that we've done for performance aspect, once we get beyond that 6 to 8%, we start to see some deficits in performance. So they're not going to perform as well if they were actually going to be competing. But that also starts to begin to characterize the potential for injury, right? Remember that running is highly repetitive and we do a lot of repetitions over and over and over and over again. And so imagine again, like your automobile, that, one side is not running appropriately on its tire. You don't notice it immediately, but it's something that over time becomes very problematic. This is one of the characteristics that no low-tech device and even high-tech devices can really be able to characterize. I just came from an event last week, the National Athletic Trainers Association. That's the largest organization that we have for what are referred to as a sports physiotherapist in the United States. So that profession is a clinician who is dedicated to working with the physically active. And even the researchers were just very, very impressed with the fact that we can accomplish all of these different metrics with one system. And it happens very, very quickly. So the pronosupination angle gives me the trajectory of the foot as we're going through that stance phase. But it's even more than that. It's not just the position, but remember, like we've seen in the walking profile, that we also see the standard deviation. So you can see this example here. If we look at the right, that's actually a fairly normal standard deviation. So there should be some level of variability. In patients that have chronic conditions, even congenital conditions such as cerebral palsy, when we were measuring the running profiles of our Paralympians, we see that that actually shrinks down many times to zero. And that's because they worked very hard to overcome a condition. But normally, that's not how it's supposed to work. In fact, if it is zero standard deviation, some people think that that would be really good. The problem is they don't have the ability to change and respond to a changing environment, like another runner coming in front of them, jumping over a hole in the ground, whatever the case may be. There should be some level of deviation. But if it's too large, then we see there's a motor control problem. And so there's an issue going on with their ability to control that. We also look at how rapid the deviation goes from when the foot heel strikes to when they come in foot flat. And if we transition from a supinated position extreme into that flat foot position, which should be in a fairly neutral position, we also see that potentially is another motor control pattern because it's too large or too rapid of that deviation. You can't see that just by watching someone because we're dealing with, certain single digit degrees as well as only milliseconds. We also get to see the attack angle as well as the force. Our system literally tells us whether or not they were heel striking or they were front foot or midfoot striking. So I don't have to worry about trying to visualize that. Our system does that. We also get the relative impact force, which again is very important because we want to make sure that we don't have too large of an impact force. We do need some, we do come in contact with the ground, but it should also be quite symmetrical. And when we see the asymmetry, that becomes problematic. This is one of my favorite features. As I mentioned earlier, we can look at this comparison. So in your typical 10-minute running protocol, we have them, do some jogging in place, and then we get them warmed up, and then we have a 5-minute jog, and then we go to a very high peak running, and then we go to back to a normal running pace. And I'll talk about another opportunity that we have here in a moment. So we can actually look at some characteristics of some different running speeds, or as I mentioned earlier, if we notice that a patient actually starts to experience some pain, discomfort, whatever abnormalities, we can actually look at all the characteristics and the differences between those 2 points. So we actually get an evolution within that same running analysis, which is pretty amazing if you think about what that would take or what kind of technology would be required to do that. I do another thing. I actually do 2 different running speeds over the course of time to again look at the comparison between those 2 evolutions. So this is just running at 6.8 miles per hour versus 7.6. So that's about a 10% difference. And so I do that on purpose because we know that 10% difference actually creates an increase in the physical stress. Think about it like this, that it's very similar to if you were performing an orthopedic test, right? We provide some pressure in different positions to stress different tissues to further identify. So for example, if this runner came to me and they were limited in their running speed, they wanted to improve, but when they improve, they start to have issues. And as you can see right here, just a quick comparison, we do see that at the different speeds, we do see a slight increase in the cadence, but we start to see a 2 times increase in asymmetry. So as I mentioned, we start to approach where it becomes problematic. The other thing that we also start to see, so one, we can identify that there are some issues with regards to their running pattern, that we see that on that left foot, they don't tend to transition over. They don't have really good toe off. They remain over on the middle to the lateral aspect of those rays. And also what you see here is an increase in that standard deviation as a result of increasing speed. In other words, they're problematic, but they really are just not prepared to start running at that speed. And we would have to make some changes if we wanted to be consistent and if we wanted to reduce their chances of injury. So what we have is an opportunity to really inform the sports physiotherapist and do a better job at maximizing the benefits with these patients. So if they're already that sports physiotherapist and they're doing running analysis, we need to find out what exactly it is that they're doing and show them that, we have much better information that can do a better job, but also as a potential outreach program. So an expansion into what I can actually accomplish in the clinic. I work with a lot of sports teams, and so it's important that we minimize the effects of injury, and we want to make sure that we maximize the overall performance. So as you can see, we've got a slightly different dashboard that we have in the walking profile. Similar, it's not so different that we would have to retrain a clinician who is using the walking profile, but just remember that there are some differences in some of the characteristics. And again, they would want to know a little bit more about the running gait, the patterns, the musculature, the expectations, maybe a little bit about how to introduce certain performance aspects. But again, very, very similar feel in how it looks. So it really allows us to have a lot of information very quickly. We typically like to have people run for about 10 minutes at their preferred running pace. I can shorten that. It doesn't have to necessarily be that long, but that's how we actually also overstress the system, right? There's multiple ways that we can introduce a stress test, from the physical aspect. And so we can run them at a longer duration at faster speeds, or we can run them at faster speeds at a shorter duration. So it allows us to characterize and provide real close information. As I mentioned earlier, when we can look at something very quickly at the nomenclature, what we see on the dashboard, it doesn't take someone who's very, very highly trained to see that they have a very low cadence, and that's something that we're going to need to work on as an example for instance. Again, the evolution is a really important aspect in that we can have them overstride or over speed at certain aspects. We can have them run uphill and look at the variations. Different stresses within the same running profile is something that is very unique and very difficult for almost any other system to accomplish, to provide a lot of data from this. Asymmetry, attack type, again, real important information, very simple for everyone to understand that it's not difficult to know that, as we start to approach that 6 or 8%, especially when we hit the 10%, asymmetry is a problem, and we know that's going to be contact time. And then we look at the attack type and wonder, well, maybe it's a difference in how they're actually impacting, the amount of force that they're impacting, and what needs to be done. We also know that there are certain percentages, at least at some consistent running speeds, we tend to see the 60-40 that we find in walking start to transition a little bit more. We'll spend a little bit more time in that flight phase. But what is really simple to look at, remember that stride length is really important in running, and we see a dramatic difference between these two, which also means that we have a dramatic difference, 33 versus 36% in contact time. So it doesn't tell me, what the reason is in their increase in contact time, but it tells me that that's something I need to investigate further, and it could be their contact profile. So that's what we're looking at here is their pronosupination angle. As I mentioned earlier, we always want symmetry, and you can see that on this left side, we do start to see slight orientation to not going to that first and second ray. So they're stating on the lateral aspect, and there's also a larger deviation on that side. Even though the angles are very similar, someone who is looking at that just observation, even with a camera view, they're not going to be able to pick that up. And those are important types of characteristics. This is one of my favorite parts, as I keep mentioning over and over again, is I can click on two aspects and I can do this comparison between these 2 points. And so, for example, when I see some differences, and maybe, or like I said, we related that to an increase in speed, or they were running uphill at that moment in time, we can actually look at the difference between those 2 points and characterize that running profile. So as you can see here, we went from +4% to +14%. So whatever that environment was, whatever that change was, it now became very, very dramatic and is something that we want to take into consideration. And if you noted and you looked at this picture and you look at the attack, we see that we started to transition from a heel striker to a flat foot or midfoot striker. Why? Well, we need to further investigate and look at some of that information a little bit further. But again, something that is really, real difficult. But in any event, it allows us to quantify that, right? So it's not my opinion. And that's also something very important, that when I show patients or I show athletes that here's the data, and it's not my opinion, we're actually able to collect this information, and we'll be able to perform an intervention, and we'll be able to then follow up and look at what needs to happen again. So we've got the quantification data throughout the whole course of that running profile. And as we see the evolution, as we're training, we actually can see some differences with regards to what's going on with the patient. The other thing that's also important to do is when I want to change their shoes. So we have a couple different options. I use some heel lifts that can also go on top of the inserts that we use, but we can put the inserts in various types of shoes. Maybe they need a lower drop, maybe they need a higher drop, maybe they need a supinator shoe versus a pronator shoe, but again, allows us real quantifiable information to look at some of these differences. I had one of our university cross-country runners, and he was a junior, so he was in his 3rd year at university, and he was saying that he was stalled, he wasn't improving, and we measure him, and he had a 27% asymmetry in his contact time, which is amazing that no one was able to pick that up. And one of the things that we identified was, he needed to change his shoes, and he couldn't understand what was the difference. Well, when you enter college versus 3 years later, there's a lot of differences. So depending on the level of maturity, they tend to gain weight. And so, well, their profile changes. So we also are able to quantify as we start to change and we go through the progression of rehabilitation, re-education, athleticism, and eventually into return to play, we can see some of the differences and know whether or not, yep, we're able to start to transition from a balance to something that has a higher concentric phase, to something that has a higher eccentric phase, to eventually addressing that amortization phase, which is going to be very important. Quick little clinical case study. She's a 30-year-old woman, 40 kilograms, high-level runner, ended up with a fracture in the second metatarsal of her left foot, then in the right foot. Now, when it comes to stress fractures, those are problematic because they take a long time to heal. And a lot of times in some of these runners, they have issues with that capacity to heal. They tend to be lower, their dietary profile needs are different, and they don't want to stop running, which means that if you know anything about healing of bone fractures, we need to immobilize that area for the transition, the callus to build, and eventually get new osseous material to build in there. But first, we need to look at also what's going on with why she ended up with some of these issues. So we know that she started with the left foot, and then we transitioned to the right foot, and we can see that wearing these different shoes, we actually have some different landing profiles. So we see the highest one here in the Brooks in the middle here. And there's also a difference in her overall gait pattern, right? And we know that whatever it is that we want to do, we want to make sure that we try and induce and create the appropriate symmetry between those two. We also see some differences with regards to her contact time. And again, looking at that characteristic between the stride length is also going to be important to make sure that we maximize the symmetry between those two. So in that stress fracture scenario, usually it's as a result of impact, right? It's constant, it's over. It's multifactorial, right? There's usually some dietary constraints. it's volume load. So we're looking at the load profile of, how much she's running. But a lot of times we also know that there's a lot of runners that have very, very large load profiles, volume profiles, excuse me, that don't get stress fractures. So it usually has more to do with their orientation and the mechanics of how they actually run. So I think we're nearing the end here. So as we've mentioned before, we've got the capacity to perform motion analysis, as we've already talked about the elderly, we've talked about the pediatrics, and now we're getting into the sports. And so we've got a lot of information that we can provide in these various aspects. Like I said, some variables are going to be a little bit more than others, depending on the group. But that's why we have differences, and we don't have the exact same profile. As you know, we're coming out with a performance rehab module, and that was something that we presented here in the United States, which again is even different. It's similar, so there's going to be some similar language in the way that people will see how the dashboard actually works, and even a lot of the same metrics in there and how to tie that together. So for example, when I do see a difference in contact time, asymmetry in contact time, I always follow it up with a jumping assessment, right? To identify, what is going on, and to be able to look at and characterize things like the ground contact time, which is something that you're going to be able to see and use. So we can look at how all these things tie together. And as with the others, we get the evolution profile. So we get the ability to look at the transition as we've gone through the rehabilitation, or as we've gone through the relative training. We can do the comparison between two different times. We're also working on, eventually we're going to have that telehealth monitoring capabilities. I find that, and we're working on a project, then we're showing the patients these profiles. Really improves communication. It's easy to understand. It's easy to explain from the clinician's point of view. Once they learn how to evaluate it, it's really quick. It doesn't take a lot of time, which is really important, because we usually get paid the same amount, whether we're spending a lot of time or a little bit of time, based on movement evaluation screening. Provides a lot of motivation to the patients, as well as their support, which includes the parents, which includes coaches, which includes administrators. And it's also easy, as we're working as a team with other healthcare practitioners, to share this among all of us. And even though if I'm working with a pediatrician who specializes in taking care of the health of a young person, or a geriatric specialist, they don't have the background in movement analysis, but it's a real simple and easy tool to understand. Doesn't take a lot of time. I usually run an analysis on every single patient at the beginning. It just adds a couple more minutes. But what we find is the usefulness of the data is really important at obtaining communication, compliance. I get new patients. People think that, they feel like they're getting a better level of care with it, but able to see that evolution throughout the course of treatment. And it really does present extremely well and make the clinician be viewed as the expert in their specific field, because we are using data, and that it's I want to even say the future. It's the now, and we need to be able to grasp it. But we were even told, I had one person who actually is another manufacturer, and he said, wow, he said, you are so far ahead of your competitors in all of these metrics. We're still working on things, and how to be able to, put all that together for some of these clinicians and present it appropriately. But that's exactly what we're trying to accomplish. And so we just keep adding to the opportunities here. Anterior cruciate ligament. Again, last week I spent a lot of time on looking at this, and the majority of these conditions actually occur in the younger patients, and that we need to do a better job as clinicians at minimizing that. Like, we know the data, we know that, typically the ratio between males and females is 1 to 4.5, and even 5 within that specific age group. We know the types of athletic conditions that they play in that tend to induce this type of energy more so. We have all the data that says, why, but we're not really good at preventing it still. And it's because people are not able to assess that consistently and provide the appropriate information that we can use in a better way to reduce the risk of injury, but also when it does happen, and it does happen, in how we can get the return to play so it doesn't happen again. So as we're continuing in the segmentation and targeting, we're working through. We're going from door to door to hopefully expand your opportunities within the different settings, but also as you work in some of these clinics that have a very diverse group of population that some of these folks work with. So many targets, again, the low hanging fruit, as we say in the United States, the groups that are much easier to introduce this to because they already envision, and that's important, is the implementation. They already envision what they can do with this technology and how to implement it. And in fact, they've been asking for it. They've been looking for technology that provides exactly what it is that we're presenting. And then also an opportunity for what we call the more difficult fruit to get to. That's going to require a little bit more information, a little bit more training, but there's more of them and there's a lot of opportunity in there. So continuation, providing more information, same system, better diversification in what we can do with the opportunity, a lot of quantification, the quality of movement. And actually, when I was meeting with one of our colleagues, he says, oh, so we not only assess, your quality, but we also assess, how poorly they move. That's another way to look at it, which is important, or how dangerous they move and how dangerous they are to themselves. And so having that ability to understand and assess all of these risks, be able to provide it to the individuals who are giving them, either the clinicians or the sports performance specialists, to make sure that they develop an appropriate individualized program and be able to communicate all that information real easily. It's all about time and making sure that we get to it. So VLR, the vertical loading rate, so that's the rate at which we impact the force. So that has application sort of across the board. It's actually one of our metrics that we also use to look at patients and potentially predict the level or the degree of knee osteoarthritis, leg stiffness, telemonitoring, video, pediatric. So we're working on honing some of these things in. I've already been working with the video. I really like the addition, and it showed really, really well. And many people were pretty interested in it. Sales incentive program. I believe this is something that you've already been introduced to. So I believe that they're going to continue running through this. And this is looking at the different characteristics of what we have available with regards to the metrics and the different walking versus the running application. And I think that's about it. Woo!
Okay, Chris, thank you very much for the great and useful and really efficient training and presentation. I think it will help to our distributors and their sales reps and agents to open much more doors and fast. I want to say to the distributors that are here and those who are going to watch it actually later on, please share it with all the sales agents, with all the sales reps. We are doing this training in order all of the sales reps will be aware how to present these features, this particular case of running, which is quite big in the market of physiotherapists. If you have any questions, don't hesitate to send it to us. We will share it with Chris. We will send you answers ASAP. If you want meeting face-to-face to go a little bit more in details about this training, don't hesitate. We are here to give you the right service, the answers for all your questions. This is our job. This is our goal. Something else to add that I missed, Rana?
I would just like to add, thank you, Oscar. I would just like to add that I've added a small poll question with 4 answers just to see how relevant you find this training and how useful it would be for you and your sales team. So it would be interesting to see your replies. And I would ask you, but without a poll, just if you can put into the chat what topics you would like to see next for sales training, so that we could work on them during the summer and be ready with Chris on September, October to present you with those trainings. So far, we have opened 3 doors. So we've done the elderly, we've done the pediatric approaches, and now we did the sports approach, as those are the most priority topics that are being used today by practitioners. So please suggest to us your topic or whatever is of interest to you, so that we could work on it. And if somebody would like to participate in voice and camera, you're welcome. You just click on participate down towards the bottom of the screen on a little bit on the left side, and you can join us and ask your question live, or you could type it in the chat, whatever you like. So looking forward to see your suggested topics.
I think for the moment it's okay. So thank you very much, Chris. It was great. I think we work together tomorrow, huh?
Yes, tomorrow there's a webinar targeted for Greece at 8 p.m. France time. If somebody would like to join in, please be our guests. It will be in English and translated in Greek, so at least it will be in English, the information, and you could it's mainly the topic of elderly, and if you would like to join in, you are more than welcome. But it's targeted to Greece as a country, and you could join us as well and perhaps have an idea of how it goes, so that you will be preparing your next webinar very soon.
Good. So you wanted the test also for me. I see you sent the email and said we can do a test, but I don't remember. I really missed that. So Stefanos informed me. And so
okay, repeat this just after the end of this event. You can stay here online,
yes.
even when the event ends, and I will talk to you. I will explain to you.
Great.
Okay. For the others, is there anything else? Any questions? Any topic you want to suggest? Or you can send by email, of course, your requests. Okay, so apparently nothing. So we thank you for joining us today. We hope you enjoyed this. We will send you the presentation and the video link by email tomorrow or Friday. And we look forward to having you in our future trainings as well. Thank you, Chris. Thank you, Oscar.
Thank you, Chris. Thank you.
Thank you. Everybody, please stay.
Yes, I will stay. I will stay.
Okay, great. Thank you, Chris. Bye.
Thank you, Chris. Bye. Bye. Take care. By the way, we are still live. Can we?
Yes, I'm ending the event.